Our next speaker is Dr. Kuritzky. I hope I'm pronouncing that right. I don't know him. He's in family physician at the University of Florida, and I will not go through his resume, but he's going to tell us things I wish I knew last year. And I don't know if this is a medical talk or related to other things that I wish I knew last year, but I'm looking forward to it. Do you want...
All right, is the sound working okay in the back? Can you see me in the back? We'll start with that, okay. Do you have room to learn 5 more things? I know it's been a long, long day. Been very, very patient. And I know that not all questions have answers. I remember their colleague here asking about their 90-year-old patient. I had a private practice as a GP in Los Angeles in the 1970s. And I remember very distinctly learning a lesson about the limitations of being a physician. A woman came from an apartment house a little ways away, 85 years old, and she wasn't one that took to doctors, but because a little girl who lived down the hall said, "Oh, go see Dr. K, he's a nice guy, you won't mind him." She had some arthritis pain in her hand, and it bothered her because she couldn't do her gardening. And so she normally didn't come to doctors. She hadn't been to see a physician since her last child was delivered in her late 30s, and had done just fine, thank you very much. And so she says, "Now, young man, tell me what's the matter with my thumb and let me out of here." So I looked at her thumb, looked pretty typical of osteoarthritis, and she said, "Well, let's take an x-ray, make sure you're not just being guessing at this." So I took the x-ray and saw typical DJD changes, and she said, "Now, what's the cause of this hand trouble I'm having?" I said, "Well, ma'am, it's something we call osteoarthritis." And she said, "What's the cause of it then?" So it's generally just something associated with aging. She said, "You doctors, what do you know? All my fingers are the same age. How come this one has arthritis?" So I had to say that she was right on that one. The lecture we're going to share together today is called 5 Things I Wish I Knew Last Year. Now, how many of you are primary care physicians? Okay, and how many nurse practitioners, PAs? Any neurologists? Endocrinologists? Some of you are unemployed. I mean, I'm glad you're in a safe, warm place, but this should have something of utility no matter what your sphere of practice. The way this lecture came about is honestly just like this. This is what happened to me in the 1980s. I was sitting in the emergency room one day, and it must have looked very much like a Hallmark card situation. The gurney was here. Mom was sitting on the gurney with her little 5-year-old holding his arm, and on the view box was an x-ray. And I had a sufficiently puzzled look on my face that an orthopedist friend of mine walking down the hall, by the way, we call a double-blind study 2 orthopedists looking at an EKG. But anyway, with the orthopedist, he saw this puzzled look on my face. He calls me out. He says, "Hey, Lou, what's going on?" I said, "I don't know. This little kid won't move his arm. He won't let me touch it. And I don't see anything wrong in the x-ray." So the orthopedist says, "Well, let's go back in and talk to her." And he says, "Mom, did you happen to pick up little Johnny by his arm to lift him up?" And sure enough, that's what it was. And some of you are already nodding your head because you know about radial head subluxation. Well, apparently I missed that day in medical school when they talked about radial head subluxation, and probably missed it plenty of times before. The trouble is in medicine, there's a bazillion things like that, little tricks that you'd wish, darn it, I wish I'd known that before. Like our colleague who just talked about the hyperkalemia, there was a letter in Lancet talking about a patient who kept getting hyperkalemia. They couldn't figure out why. It was because of apple juice. They said that all of us in medical school, if you say hyperkalemia, the first word out of a health professional's mouth is bananas. But you know what? No primate that has a hairless body can eat enough bananas to give them hyperkalemia. There's too many calories in it. People don't do that. But apple juice, even though it has relatively lesser amount of potassium per gram, some people consume huge quantities of apple juice, and they don't think of that as a potential source. Since what you see on the list, and I was looking at the list our colleague showed us, didn't have anything about apple juice on it. So, another little thing like that. So the way this talk evolved was, after I had my misadventure with a little kid in the radial head subluxation, I started making a list of things to which my colleagues, residents, medical students would give me the response, "Wow, I wish I'd known that last year." And it's rarely something that appeared in New England Journal, because if it appeared in NEJM, all of us would know it. It would be trumpeted all over the land. It's usually sort of out-of-the-way things. And I started putting them into a lecture, and I go around giving audiences like yourselves lectures with the idea that of the content, there should be at least 5 things in there that not only did you not know them, but you think are worth keeping. So, for instance, if I ask you what my mother's maiden name is, you don't know, but you don't care. It doesn't make any difference. So this presentation should have at least 5 things you wish you knew last year. It has been vetted, and what that means is it's been presented to an audience of at least 200, of which everyone in the audience said there were at least 5 things they wish they had known last year in the presentation. I also invite you, if you have things that you've come across in your practice, you say, darn it, I wish more people knew about this. Like we were talking about the alcoholism earlier. There's a trial in people with the alcohol. There's a number of things that do it. The alcohol withdrawal, because remember the guy who's been drinking all weekend and then clears the bottle for a couple days so he can come see you. He's an alcohol withdrawal. It's pushing his blood pressure up. Because he's alcoholic, he doesn't take his medicine with reliability. And then the alcohol has independent effects that are direct. But there's an interesting trial of alcoholics who didn't want to be admitted, and they got baclofen, 10 milligrams every 8 hours around the clock, 30 days. They have to enter the trial with a severe score on the alcohol withdrawal scale. Within 2 hours, all of them are down to the minor or no symptoms. Baclofen for alcohol withdrawal. So anyway, I invite you, if you have referenced, and reference is the key, because even if you tell me, hey, Lou, you know what? I've always found if you see a patient with pink eye, my grandma said, put a slice of cucumber on the eye and that'll draw the inflammation out. Although I'm willing to try it myself, I'm not willing to stand in front of an august audience of our colleagues unless it is double-blind, randomized, placebo-controlled, Crosby, Stills, Nash, Young, Sears, and Roebuck trial that says it is fact. As a matter of fact, about 8 years ago, there was an article published in New England Journal trying to ascertain whether pathologic sinusitis is part of the course of the common cold. They took a couple dozen young adults and they snuffed 5 different rhinoviruses up their nose because they wanted to be sure that at least one of them would take hold and cause a clinical infection. And then they did CTs of their sinuses every 48 to 72 hours for 20 days to prove that indeed you do get sinusitis as part of the common cold. Well, an irate reader wrote back and said, how dare you use up valuable resources, radiate these people heavily, to come to a conclusion that my grandmother told me when I was a small boy. Shame on you. And the authors responded, with all due respect, because we were unable to locate any literature by your grandmother, we had to review the old-fashioned tool and do it scientifically. So if you have things that you'd like to share with your colleagues, what I'll do is I'll put them in and I'll credit you with showing us that fact that our colleagues will then get to enjoy. So this is a little different than other lectures where you ask your questions at the end, and I don't mind taking questions from your seat if you just speak loudly or relay your message up, because after each one of these cases, we'll open this up to your discussion. Sam has diabetes and hypertension. You've noticed recently that there's been a change in his BUN and creatinine. Before, it was 12 and 1, and now it's 28 and 2. He's been on stable medicine for a while. Metformin, glimepiride, that's Amaryl, lisinopril, simvastatin, and aspirin. What do you think is the culprit in this situation? Stable medicine. Well, we're going to talk about oral sodium phosphate, as is seen in sodium phosphate solutions and tablets, and compare those with other typical colonoscopy preps, like the Go Lightly and New Lightly. And by the way, the trials comparing Half Lightly, which as you see is half the volume, it's only 2 liters instead of 4 liters. And I don't know if any of you have gotten to enjoy medicine's greatest euphemism, Go Lightly. Guess again. When I had my colonoscopy, it's really hard. Even that improved flavor, the citrus-flavored antifreeze does not taste any better than regular antifreeze. It's tough to drink the stuff. So this New Lightly in a head-to-head trial has shown equal efficacy for bowel prep as the larger volume. But the reason we're talking about this is because of the phosphate load. In a typical 90 mLs of oral sodium phosphate solution, which many of us use because we felt it was kinder. If we can get this person to just drink the Fleet's Phosphosoda, and then that's only 90 mLs, that's not nearly so big a hurdle to jump over as the more complex Go Lightly with the 4 liters. Well, why are we talking about it? Well, let's look at this report from the FDA that says the FDA has become aware of recent reports of phosphate nephropathy. That's acute kidney injury for people who are using oral sodium phosphate products, that's tablets or liquid, for bowel cleansing. These include stuff that's over the counter. In some cases, there have been serious events, and the people didn't have pre-existing disease. The previous thinking prior to this report in 2008 was that the only people who got into trouble with a phosphate load were people who had unhealthy kidneys to start out with. And so when we sent healthy people in, we didn't pay any attention to what particular bowel prep we were using. We'll look at this trial that focuses specifically on this subject. They begin their trial documentation saying it was first recognized in 2005 that acute phosphate nephropathy can occur and explains what might otherwise be kidney dysfunction that we don't know the cause of. There is belief that in addition to causing an acute injury, that right after you take this phosphate solution, you can do an acute hit. There's a chronic hit that we haven't seen, and you'll understand why by this trial. This is a study from Texas. And don't go to Texas. They're always bragging there. I went, and the person who was leading the lecture said, "Young man, I want you to come out and see my farm. You've never seen anything like it. It is so huge. It'd take you the better part of the day just to drive your truck by one side of it." I said, I used to have an old truck like that too. So anyway, this is a study from Texas, and it was looking at the 3,000 people who underwent colonoscopy over a 7-year interval who had received oral sodium phosphate solution. And it also had to include that the people had been given hydration instructions, because if the people messed up and all they swallowed was the phosphate solution with no hydration, you can't blame the phosphate solution, It's like if you shove a fork in your eye, you can't blame the fork that you got blind. Did you all see that headline about that actress murdering her husband, Ssris? No, with her knife. Oh, going on. Okay. So anyway, the sodium phosphate solution has to be used properly. Those are the only folks who could get in. And the people they kept out of this trial, they don't want to falsely accuse the phosphate either. So they wouldn't let you in if you had heart failure that's headed south, because your renal function is going to head south anyhow. You got HIV disease, if you got chronic kidney disease. So they eliminated anybody who would have a competing factor. They're saying, bless you, the only thing that could cause these folks kidney trouble is if something that happened right now is causing it. So let's look at the initial stuff that's kind of subtle. We're looking in the first column at the people who got sodium phosphate, like Fleet's phosphosoda, versus the control group who didn't receive that. And you see their baseline creatinines are the same. 6 months later, the sodium phosphate group's creatinine is 1.01 versus 0.94 in the control. But you know what? You and I wouldn't see that, because when we look at the lab, all we look at is what's abnormal, right? It's still normal. All you do is you look at the lab slip, you see what says L or H next to it, and the rest of it, you just ride on past, right? That's what most of us do. I wouldn't have looked to see if there was a difference there, but it becomes more dramatic if you look instead at GFR, because we're looking at the same two groups now, sodium phosphate versus the control. And both of them start out with fairly similar GFRs, 75 to 80. But 6 months later, the phosphate group's GFR is dropped by 6, and a year later by 8, as opposed to a 1.5 drop in the control group, because we do lose GFR with aging. Here's what the authors say. Our findings suggest that the magnitude of this problem may be far greater than had been recognized because of all the healthy people who come in, and if you give them a minor hit to their renal function and their creatinine goes from 0.8 to 0.97, are you going to notice that? I don't think I'm going to notice that. So they point out that in this trial, data looking at 3,000 folks, at 6 months' time they had lost 6% of their GFR, and at a year, 8%. And what they also, I think, wisely look at is these are people who only had a single hit. What about the people who regularly use phosphate as their bowel regimen to deal with constipation? What about the people who have to have repeat colonoscopy because they find a polyp or they have some high-risk disease or requires more frequent colonoscopy monitoring? These are people who had one colonoscopy one time and lost 6 to 8% of renal function in that year following the sodium phosphate. The other reason I bring this up to you is this was my preparation of choice, Fleet's phosphosoda, because it was so much kinder, it seemed, than to go lightly or the new lightly. And I advise you to do what Scott and White has done. Because of these findings, our institution has abandoned oral sodium phosphate for elective colonoscopies. They recommend PEG, which is the go lightly and new lightly, and magnesium citrate unless you have advanced renal disease. Questions, issues, thoughts about sodium phosphate and effects on renal function? Yes, sir. Yes. Our colleague asked, in this trial, the hydration issue is mentioned. Did the people in this trial have adequate hydration? Yes. One of the exclusion criteria for the trial was if you had not received and followed the appropriate hydration instructions, you couldn't get in the trial. Because if you didn't, that phosphate load is too heavy, and you shouldn't accuse the phosphate, it's the person's poor hydration. Other questions about phosphate? Okay. A 62-year-old woman, Ethel, lost her husband 6 months ago. And she thought she'd get over it. She said, well, no, I don't really like taking medicine. But she's back now 6 months later, and she says, well, maybe I'll reconsider. I'm still feeling lack of pleasure in life's activities and depressed, and not sleeping well, weight gain, feeling guilty. And when you offer her Paxil, thinking, well, gee, that would be a good one for her because she's having insomnia, works as well as anything else. Maybe I can capitalize upon the sedation aspects of that. She says, I don't know. My neighbor took that, and she had an auto accident, and she blames the Paxil. She said she drove differently, or she had impaired consciousness when she took the paroxetine. So what should you say to her? There's no relationship? Say, well, that could be, but I don't think it'll be a problem for you. Should you say, you might try Mirtazapine, Remeron, Doxepin, Sinequan? Well, let's look at this, and you'll see why this was studied in the first place. It's peculiarly of interest in the state of Florida, where I live, because we have a very peculiar driving regulation system. If your patient is taking Benadryl and has an auto accident, and it is learned they were taking Benadryl when they had an auto accident, they are given the same traffic citation as driving under the influence of alcohol. It is simply driving under the influence of any consciousness-impairing substance. So that's why in our state, for instance, it makes a huge difference whether you picked Allegra, fexofenadine, or cetirizine, Zyrtec, or loratadine, Claritin, because the Claritin and the Allegra are in the non-sedating class. The Zyrtec is not. It's in the low sedation class. Only 4 to 10% of people who take the Zyrtec report sedation, but if you do driving simulation, almost 1 out of 5 of them, it shows impaired driving skills acutely with Zyrtec. And that's why they couldn't list it as a non-sedating. It is much less sedating, and most people don't get sedated. Most people do fine, but it can become a medical legal issue. So this is a trial based upon the notice that some antidepressants impair psychomotor function like driving. Now, you and I would have hoped that, well, all right, people will accommodate to the sedation. This lady's having insomnia. That can produce poor driving skills, too, because she has next-day fatigue. We hope that it'll improve her daytime alertness if we help her to sleep better. But it's kind of a balance beam trick there to wonder about which is going to win out. Here's the study using Mirtazapine in driving. They did 3 things. First, they were making sure that the Mirtazapine did work for depression, and that's already well established. And they did a driving simulation and a wakefulness test. Here's how they did it. First off, they did the testing within 48 hours after people started medicine, then at day 9, 16, 30. And then they repeated these tests looking at driving skills and your wakefulness 4 times during each day, 10, noon, 2, and 4. So what did they do? If you're looking at the driving simulation, they looked at how well you stayed in your lane. Did you watch the speed limit signs and adhere? And then there's a thing in the machine that creates what's called a virtual gust of wind. It moves your car like you got hit by a gust of wind and sees if you recenter it properly and sees how many crashes that you had. The maintenance of wakeful test was a little bit tougher. They put you in a dark, soundproof room, lie you down flat and say, stay awake. And they see how long it takes for you to fall asleep. And that's called the sleep latency test to see how long people will stay awake. Well, here's what happened. With the Mirtazapine, road positioning and crashes actually improved. Sleep latency, a reduction is bad, means you fell asleep more quickly. So there was, at day 2, a reduction in sleep latency, but no other time. So after the first 48 hours, people had the same alertness they had, bless you, with no drug at all. What do the authors say why is this pertinent? Because These findings are not true with other agents. In the article with the data that I just showed you, they report the findings from this article that they had looked at to include in their disposition of why are we doing this study in the first place. You'll see 4 different categories or specific drugs listed, and the ones in the green are people who passed driving simulator tests, and the ones who have severe impairment, and the middle mild impairment. So when you look at the green, you'll see that clearly many more people on mirtazapine pass their driving test than anything else. And when you look at severe impairment, notice that there is a small but meaningful minority of folks on tricyclics, venlafaxine as effexor, a variety of SSRIs, different from mirtazapine with severe impairment. So in Florida in particular, I do make a choice. If the person's going to be on an antihistamine for their allergic rhinitis, I'm going to tell them, now, if you're going to choose this Zyrtec, if that's your favorite one, you got to be careful now because there is regulation about that. And the same thing with these driving misadventures. Questions about this data on driving impairment and SSRIs? Yes, sir. Our colleague asked, are any of these warnings in the package insert? I haven't looked at all the other package inserts in specific for a warning. However, all of them do include things like sedation as an adverse effect, so it is a listed effect. Is there another question? Over there. Which population was looked at, did you say? I don't know the age group in this population. Does anybody know from this data set what the age was in the population? I really don't know. I can get that to you, though, if you'll speak with me afterwards. Yes, sir.
Was there different SSRIs checked? Do you know which one they used?
The one that says SRIs had looked at several different SSRIs.
They're all about the same?
I don't know. Our colleague wants to know, is there a difference among the SSRIs? For instance, you would expect that some SSRIs would be less sedating than others, and typically we do think of Paxil as the most sedating, right? Yeah. Yes, miss. Well, there's a funny thing with the mirtazapine in that the sedation appears to be at the very lowest doses. And when you get to a mid-range medium dose, it doesn't seem to have those same effects. Remember how we noticed with venlafaxine. At the lowest doses, it's primarily serotonergic. And then when you get at doses of 225 or above, that's when you start to get tachycardia and hypertension because it becomes more norepinephrinergic at those doses. So why it interacts with different receptors with different efficacy at different doses is explained by the pharmacodynamics of the drug. It does differ with mirtazapine at different doses the same way effexor does. Yes, sir. The liability of the prescribing physician. Well, anytime you give a person a consciousness sedating product that has that potential and don't warn them about it, you are potentially liable. Just have to warn them that it can be sedating, yes. Right. Okay, little Johnny has a cough. Johnny's a 5-year-old boy, and his mother brings him in and says he's been coughing for 3 days. You examine him, you think he's got a viral URI, and Mom said, well, can you do something about his cough, which is keeping him up at night, which also means it's keeping me up at night? And what should you recommend? Honey, dextromethorphan, Benadryl, phenylpropanolamine, or wait it out? Well, here is a comparison trial using honey or dextromethorphan or placebo, looking at cough and sleep in the child and their parent. This is based upon the observation that cough is an important reason for folks to visit with us, and it's particularly bothersome at night. Why is it particularly bothersome at night? Lots of ideas about that. Is it just because when we want to be sleeping, any interruption is more traumatic? Is it because of the physical nature that when we lie flat, there's different activity of our nares than when we're superior? Is it because when you have postnasal drip during the day and you can clear your throat like that when you're standing, it's not so easy when you're sleeping and it interrupts you? Is it because there's waning of cortisol late at night? Lots of factors could be contributing. Be that as it may, most people are more bothered with cough at night than other times during the day. representing the most popular antitussive in America is dextromethorphan, even though neither the American Academy of Pediatrics or American College of Physicians advocates for it. So here's a fairly reasonably sized study, and there are some of the things I might show you that you might be critical of the N. The N. You might say, oh, come on, Kuritzky, there's only 7 patients. But you know what? If everybody in a room gets bitten by a rabid dog, and one person who eats a lot of broccoli survives, you better look at that broccoli real closely to find out what's different about that. I don't mind studies that have a small N. There was a report in New England Journal, letter to the editor, a woman post-stroke had expressive aphasia, was complete. She had been through all the speech rehab, and expressive aphasia is a dreadful burden to people because not only are they not able to say anything sensible, but when they try to speak, the more frustrated they get. The more words come out that they would not previously have used in polite conversation because primitive centers start feeding that type of jargon and it comes out, and then they become embarrassed and upset because they can't talk. So listen to this single case report that I saw that I think could help somebody. This woman had expressive aphasia. She had completely, through her speech therapy, she couldn't say anything reliable. One night they gave the lady Ambien, Zolpidem, because she had been agitated during the day. She started talking sensibly till she fell asleep. And then they tried it again. They brought the woman in, and they found that Ambien, Zolpidem, actually previously unknown, increases circulation to Broca's speech area. And they said, well, maybe in people who have marginal relative remains of circulation that's still there that could be augmented, this could be a useful tool to restore speech, and maybe we could find a dose that would be able to restore speech and not be so sedative that the person wouldn't be functional after that. But it was only a single case report, but what do you got to lose at that stage? You don't have anything else you can do, so why not try it? If it helps somebody, you win. So this is a study more substantial, 100 folks, and they're, bless you, as you see, ages 2 to 18, and they've had viral URI symptoms for less than a week, and again, very sensible exclusions. They're not going to cloud the issue with people with asthma because they cough at night anyhow. Or SSRIs, they're going to give people dextromethorphan, and dextromethorphan is metabolized through the 2D6 system. So they don't want people who are on SSRIs to have to wrestle with that. So they gave folks honey-flavored dextromethorphan or an equivalent volume of buckwheat honey. There's no dose here because what they did was they said, all right, you take this bottle of dextromethorphan, here's the guidance for your child, give them as much dextromethorphan as is indicated for age. They gave the same dosing schedule for the volume of honey as they gave for dextromethorphan liquid. And here's what happened. Night 1 is in the green, night 2 is in the red. And as you'll see, there was a significant decrease in cough frequency with honey that was not statistically significantly different from dextromethorphan, so it worked as well, looked actually even a little better. And the same thing for the comparison of the honey was superior statistically to no treatment at all. Let's look at the child's sleep pattern. Very similar numbers. Night 2, you see a dramatic improvement in sleep on honey, as good or better than that achieved with dextromethorphan, and statistically superior to placebo. And they did actually measure the parents' sleep also, and the parents' sleep was improved in the same fashion as the child's sleep was improved. So the authors conclude their study with the commentary. Results of this study demonstrate that in the overall comparison, honey was the most effective treatment for parent sleep, child sleep, cough, well tolerated and safe. I am told that they chose buckwheat honey because it had historically a greater notoriety, that people thought buckwheat honey was better for cough just by tradition without any science. But what I caution you is if you're looking for buckwheat honey, because you don't find it in all the regular grocery stores and stuff, don't just Google the word honey because other types of honeys will show up that you weren't particularly interested in seeing. So make sure you put in buckwheat honey when you do that search. Questions about honey as a real-life method to treat cough. And by the way, some of the other measures like chicken soup was actually reported in chest. They did a study to see if chicken soup would change the cough in acute bronchitis, and it did not. One of the reviewers then said, well, maybe you didn't give the right dose. So I don't know if we'll ever know about chicken soup. Yes, sir. They gave, to repeat the dose, you look up the dose that they gave Because remember, these kids were in age from 2 to 18. So you use whatever volume of dextromethorphan was appropriate for that age. They gave the same volume of buckwheat honey. So if it was a 6-year-old kid and you would get 2 teaspoons of dextromethorphan for a 6-year-old kid, they gave you 2 teaspoons of buckwheat honey. And that was in order to maintain the blinding so that people wouldn't know which one they were getting because the volume was exactly the same. Yes, sir?
So what is the active ingredient in honey that doesn't?
Nobody knows the active ingredient in honey. A colleague asked, what is the active ingredient? Yes, sir?
Years ago, I did read a study about chicken soup and respiratory infection. Homemade soup versus canned chicken soup has to be homemade and does improve.
Our colleague reminds us that he has seen a study that compared what might be called synthetic chicken soup in the can from the mother's loving hand of homemade, and our colleague reports that in this trial there was a difference in outcome favoring the homemade chicken soup. So maybe the constituents or the freshness or something about the fresh made soup really does make a difference. Thank you for sharing that. That's the kind. Share that with me later. I'd love to share that with our colleagues. Other comments on honey? Buckwheat honey. Okay. Now Johnny has an earache. Johnny's a 5-year-old boy. Mother says he's been crying, complaining of ear pain. His temperature was over 100, but it's normal this morning. He doesn't look sick. When you look at his ear, it's red, bulging, dull. What's going to work for him? Could you give him systemic antibiotics, topical antibiotics, systemic analgesia like acetaminophen, or should you give topical analgesia? Well, you will be able to tell this is a study of British origin because of the way they spell lidocaine and randomized. So this is actually from Australia. Double-blind placebo-controlled trial. And they review in their data, beginning with the Cochrane analysis, that talked about antibiotics for otitis media. We're doing better with that. I like the British version of antibiotics for otitis media. Have you all heard the philosophy of the SNAP prescription, safety net antibiotic prescription? That's where mom comes in. She's got little Johnny. He does have otitis media. And you say, Mom, we're trying to avoid use of unnecessary antibiotics in kids with earaches if we can avoid it. I think your child will likely be past this. If we can just wait 48 hours, he'll turn the corner with no antibiotics at all. I'm going to give you this prescription so that you can have it. If he gets any worse, fill it. And if he's not better in 2 days, fill it. Well, the outcomes of 2 trials that have looked at that methodology were very similar. First of all, half of the moms fill the prescription as soon as they walk out the door anyway, okay? Another half of the remainder, so another 25%, they fill the prescription within the next 48 hours. But that does 2 important things. First off, even though it's only 25%, it does reduce the utilization of antibiotics 25%. But the most important thing, it's a two-flavored message. Flavor number 1 is, Mom, we care too much about your kid. We don't just give antibiotics. They can be consequential. We don't want your child to have unnecessary expense, unnecessary adverse effect from the medicine. We don't want to create resistance in the population. We don't take this lightly. I'm not meaning to be unkind, so I'm going to give you this backup prescription if you need it. But we don't just give antibiotics because your child has an ear infection. So this is looking at other things besides antibiotics. Double-blind randomized trial of 63 kids. And they take lidocaine, that's just like the stuff you use for lidocaine injection, 2%, and drip it into the ear versus saline. And they put 3 drops in, and then you're supposed to have that side up so that it doesn't drip out. Oh, by the way, wonderful trick I learned with kids. You know, if you're trying to get eye drops into a little 3 to 7-year-old who doesn't want the eye drops in there, you could be Arnold Schwarzenegger. You're not going to get those eyelids open. It is not possible. But here's the way to do it. You have the kid lie down flat on his back, close his eyes, put the drops at the medial canthus. As soon as he opens his eyes, the drops will run in effortlessly. No muss, no fuss, no chocolate mess. Real simple way to do it. So here's the way for the ear pain. Lidocaine, 2%. And if they said, yeah, it works, but the pain's coming back, they could put it in again. And they said, you can take this home if you find it useful, and you can give it up to every hour if you want to relieve pain if you need it. And as far as antibiotics went, in this particular trial, it was up to the physician to decide whether kids would get antibiotics or not. The threshold that they used was a 50% decrease in pain. This is actually a very high threshold. The pain literature in general, not otitis media pain, but people who have chronic pain like osteoarthritis or HIV neuropathy or chronic cancer pain, The pain literature says that patients consider a 30% from baseline reduction as a meaningful reduction. 50% they consider marked improvement. So we would expect that children would likely feel the same. And here's the map of what happened. The red are the placebo, and the blue boxes are the lidocaine. And you'll see there was a statistically significant difference favoring lidocaine drops at the ability to reduce pain by 50%. The authors go on to point out there's a misspelling here. There should be Auralgan, A-U-R-A-L-G-A-N, which contains another topical anesthetic, has been studied in a placebo-controlled trial. And they were only able to get a 25% reduction, which is why I mentioned to you this is a very high hurdle they had at their thresholds. And they were only able to get it at 30 minutes. In this trial, you see at 10 minutes, see where the first mark is on the scale? They go from 0 to 30 minutes. At 10 minutes, there was already a statistically significant reduction in pain compared to placebo. The Auralgan was only able to prove it at 30 minutes. There's no serious adverse effects known from topical lidocaine. It is not recommended if you have a perforated TM, so that the mothers were instructed when you go home, if your child starts to have an ear discharge, independent of when you put the 3 drops in, or if it's a purulent-looking discharge, don't put any more in, because the effects of the lidocaine in the middle ear are not known. The only antibiotic safe for perforated TM is Floxin-Odic. It's been studied with perforation, so you can even give it to kids who have grommets and PE tubes safely. Floxin-Odic. Floxin. Has anybody tried this for the lidocaine to give us yay or nay that it works or it doesn't work? Because in the previous audience I addressed in Amarillo, the one doctor had a large pediatric practice said he found it very highly effective. But when we do these things, this is 60 kids. If it doesn't work, I think it's important for you guys to speak up too. Let me tell you why that is. Remember that the literature is generated at academic medical centers. That doesn't mean that's real life. The best example I could point out to you is if you go look at the package insert of Captopril or Ramipril, and you look at the incidence of cough, you know what it's going to say? 3.5%, 4.5%. Why is that? Well, I was given a lecture in Alabama almost 20 years ago. 2 senior practitioners come up to me and say, now, Dr. K, we've been giving folks them new ACE inhibitors like y'all folks at the university said to do, and me and my friend Gus here, we see upwards of 50, 60 folks a day. Both of us been seeing a cough with ACE inhibitor. You ever heard of that? Now, this is 1986 when the drugs were new. So being an academician, I unscrolled the package insert and said, well, it says the list should be 3.5% here, Gus. And then, after sufficient clamor from clinicians, people went back and proactively sought the question, did you get a cough? And we know that 17 to 20% of people who take an ACE inhibitor get a cough, but the patient never associated this occasional with the ACE inhibitor that they took, so they didn't report it. And by the way, just because a person gets a cough on an ACE inhibitor does not mean they have to stop. There's no long-term toxicity known. If a woman came into you and she took birth control pills, and she said, well, since I've been taking the birth control pills, I have these dark splotches on my face. Does she have to stop? Only if it bothers her. Some women say, no, it doesn't bother me in the least. No? So the fact that it's an adverse event does not mean that you have to discontinue the medicine because of that. The gentleman over here about lidocaine. Good idea. So what's in Opthane? I don't know what's in it. Is it a topical lidocaine also? Proparacaine. Our colleague points out. He says that the advantage of using the Opthane, and I would hope that it would be similarly advantageous for lidocaine, it's not commented on in this study, is that with the pain gone, then you're enabled to examine the kid's ear where he might have been fussy before because he doesn't want anybody messing with the part that's hurting him. The analgesia allows you a better, more clear exam. So thank you for whoever told us this is proparacaine. Yes, sir.
Related but not directly.
Yes, sir.
When I was in medical school, I was mentored by a 70-plus-year-old gentleman who told me his eardrum was a semi-permeable membrane, so if I got sugar water at near supersaturation levels and took it on there, I would draw water across the eardrum, thereby relieving the pressure. I've used it for 4 years. It works quite well.
And how do you make, I'm going to repeat our colleague's comment because I'm sure you couldn't all hear it, but how do you make the sugar solution? What do you do?
You keep stirring it in until you haven't got any more out.
Okay.
Start with the
So our colleague tells us of a remedy that he was advised of by a senior clinician that he learned when he was a young man in training, that his preceptor told him that if you made a hypertonic solution, because the eardrum was a semi-permeable membrane, it would actually draw fluid out from behind the ear that could be causing pressure and pain. The recommendation, which he said he has tried successfully many times, is to mix enough sugar into solution that is clearly full, and then put those drops in the ear, and the osmotic pull will pull the middle ear fluid out. In Europe, tympanocentesis is commonly done in office by primary care clinicians for otitis media because of both the immediate pain relief and the diagnostic capacity. So you can send that for culture or gram stain on an immediate basis, but we're not trained here to do that. Further comments, sir? So our colleague says he has rapid response to the hypertonic solutions with the drawing the fluid out of the middle ear. Thank you for sharing that. Other thoughts, issues about? Yes, miss.
Is there any concern about systemic toxicity from lidocaine, like we worry about when we inject it? We add epi to keep it localized.
Our colleague asks, is there concern about systemic toxicity? The dose of lidocaine is very, very small. It's only a couple drops. So the milligram dose is very, very small. Okay. Let's go on to diabetes and a rash. Patient comes in, 58 years old, got a rash on their legs, had some light drainage, tried some cortisone, helped a little bit, not too much. This is the rash. What should you do about this rash, and what is it? Well, this is the very most typical appearance of this stuff called necrobiosis lipoidica diabeticorum. And as you see in this commentary from New England Journal, the exact cause is unknown. It is not correlated with the degree of glucose control. And the treatment can include, you could put dressings on it, you could put steroids, but there's nothing that's really highly effective. And here's a more close-up picture of what it looks like. It's almost always in the shins area, but you can have it on the ankles. You can have it other places on the body too, but this is the most common area. So there's a study here of pioglitazone, not used for diabetes, but used specifically for this dermatitis. Now, I had no idea until I saw this study and a letter to the editor in Journal of the American Academy of Dermatology that pioglitazone, I don't really know what intranuclear retinoid X receptor activity is, but it has something to do with retinoids, and there has been some efficacy shown with retinoids applied to the necrobiosis also. So here's what the authors tried. A 32-year-old woman had necrobiosis lipoidica diabeticorum for a year and a half. And she had tried Retin A and topical steroids, and it really hadn't helped. So they put her on pioglitazone, 7.5 milligrams for a month. She had major improvement, increased it to 15 milligrams, and the lesions progressively improved. So I don't have anything really to offer for necrobiosis. So this is what I try on patients. My experience so far is very limited, but I'm hoping that we'll have some more success with the treatment of necrobiosis because, well, I think I'm going to show you another rash like this that's problematic. Anybody tried pioglitazone for necrobiosis, or have you tried anything that you found highly effective? A man with Viagravation. 58-year-old man, and he's been taking sildenafil for the last 6 years to treat his ED. He says, but you know, in the last year, it's not working as well. We know that correction of hypogonadism can enhance the efficacy. You need to be clear. I've been practicing since Moby Dick was a guppy. I began in 1973, okay? And I used to make this mistake that when people with gray or white hair came into me and complained about sexual function, I'd say, oh, well, you're probably low testosterone. You don't need testosterone to have an erection. That was amply proven by a group from Italy called the castrati singers. Young boys were invited as an honor to have their testes removed prior to the pubertal surge. Because at puberty, when you get the testosterone surge, the reason we boys have bigger Adam's apples than girls and lower voices is just like the piano. When you look on the piano, it's the longest string that has the lowest note. Well, the testosterone stretches out our larynx, so we get longer vocal cords than girls do. And that's why our voices are lower. So if you take these boys and you take out their testicles before the pubertal surge, their larynx stays small. The boys still grow big, and they can have a larger chest cavity to create bigger volume voices. And lest you think that this is a story of antiquity, the final castrati singer died in 1976. So, and these young men, they didn't have any trouble with getting erections. Testosterone enhances the activity of endothelial nitric oxide synthase, but you don't need to have testosterone to have an erection. It's a vascular phenomenon. But the hypogonadism does make your endothelium make nitric oxide a little better. So if you're stimulating your nitric oxide enhancement with Viagra, but you're low on testosterone, it could make your Viagra not work as well. The purpose of this is to talk about how commonly do young men like Paul K., 58, how common is it that he really might be low in testosterone? And that is directly supplied to us from a large study in primary care. 130 primary care practitioners participated to provide 2,100 men over the age of 45 who come in for anything. They're not there for sexual health symptoms. They just come and see the doctor. And what did they find? They measure the total testosterone. I want to show you the bottom line here. A low testosterone is considered less than 300. Look at the range, the percentages from a low of 34% at age 45 to 50+% and as high as 60% in people over 85. So we're only recently becoming aware of hypogonadism as a prevalent entity. We don't really yet know what to do with it because there is no men's health initiative. Remember, we had the women's health initiative. All of us really thought hormone replacement therapy was a good idea for women regardless of age. If you're postmenopausal, your estrogen will do you good. And then we found out from the Women's Health Initiative, if you're starting it at age 60 plus, it's not going to do you good. Younger women, it still is beneficial. But we don't have such a study in men. There are two population studies that conflict. When you give men testosterone, their sex drive goes up right away. If they have marginal erectile performance, the endothelial nitric oxide synthase enhancement can help their erections. Their bone changes, get stronger, their muscles get stronger. So it can be really helpful to some men. But hypogonadism is not a lab test. These are the men who had an abnormal lab test. They didn't have symptoms of hypogonadism. So the number of men who actually have symptoms is much, much smaller. There's a variety of symptoms that go along with hypogonadism. I'm 65 this year, and I've had changes in my body I don't want. My son and I work out 3 days a week, and I run 2 or 3 days a week. I know you find it hard to believe looking at me that I work. Maybe some of you can advise me about this. My son, I started him working out with me when he was 18. He's now 25. He looks like Popeye. I still look like olive oil. I don't know what went wrong in his prescription here, but so anyway, so in the last 3 years, my weight has changed. I've never been a big person, but I have weight around my middle that I don't like, and it's really dreadfully difficult for me to get rid of it. My muscles, although I was never a big muscular guy, they're softer now, and I'm not as strong as I was. And I don't have the same type of overall energy I used to have when I was 55. And some of it may have to do with changes in testosterone. Plus, we Y chromosome people, you know that we accumulate SHBG, sex hormone binding globulin, and lose testosterone at the same rate. Every year, a male loses 1% of testosterone from age 25, and every year we gain 1% SHBG from age 25. Why is that important? Well, we don't know whether my testosterone 10 years ago was upper limit of normal at 900 or whether it was 400. And now that I've dipped down below the low 300s, maybe that's why my body is changing and my muscular strength isn't the same. Maybe that's why these things are happening to me. We also know that if your SHBG goes up, that it ties up your free testosterone. Free testosterone, the only part that's active. And so if I have marginal testosterone and my SHBG is rising, I'm going to have less free testosterone to stimulate strength, libido, sexual function, muscle mass. So the mnemonic for hypogonadism is problems, trouble with your penis, anemia, central obesity, low bone mineral density, low libido. That's usually what drives men in. Low energy, changes in affect and strength. And I want to give you a little bit of a fright, but just a little bit of one, because sometimes we go overboard on stuff like, you know what, if you go outside today and turn over any rock in the parking lot, there's going to be a vitamin D deficient person under there, right? Vitamin D deficiency causes everybody to have everything. We didn't measure vitamin D ever in our life 10 years ago. We never did check that, and now everybody we check, everybody's got it, right? lifeguards in Florida. They're sitting at SeaWorld 18 hours a day, vitamin D, 28, you know. So I don't know. I think we're going overboard with the vitamin D. But the testosterone thing is enough to catch our attention. I want to show you this one trial, and there are two population data sets that look exactly like this, relating low testosterone to mortality. So the upper line here on the y-axis, we're looking at survival. So the higher up you are, the more likely you are to survive. And on the x-axis, we're looking at time, followed men for 8 years. These are all veterans over the age of 40. The blue line is men who have a normal testosterone. And if you follow that blue line all the way over to 8 years, you see that 75% of men are still alive. If you look at men in the orange line with intermediate testosterone, it's down to 65%. And if you look down to the men with subnormal testosterone, it's 55%. And this has been mapped out in two large populations. Now, before you swallow that and go, uh-oh, I better check my testosterone. I got gray hair like Kuritzky. It's going to kill me. Remember that testosterone goes down with any cachexia, with chronic cancer, with chronic opioids, with chronic HIV. So some of these men are included, people who had underlying disorders that led to their demise. It was also leading to low testosterone, not the low testosterone leading to their demise. But that's only a portion of this equation. So I think we need to listen more carefully to testosterone. The reason I'm talking to you about it is because the application is now so simple. We now have 4 different topical preparations that you can put on every day if you want to, and there's injectable preparations. Europe actually has an oral preparation, the only oral that's not been shown to cause hepatotoxicity. It's absorbed differently, so it doesn't go through hepatic metabolism. So no liver trouble with it. We don't have it yet. Don't have it. And I understand it was turned down by the FDA because they said there's no long-term studies of the safety of testosterone systemically. Yes, sir. This study looked at total testosterone, but it's similar, the outcomes. Oh, yes, the other one, the one we were just talking about, yes. Our colleague says, what about free testosterone in this population? The number of persons with free testosterone low was actually even greater because of the SHBG vagaries as women. As the men age, you see as they get older, they have more SHBGs, less free testosterone. So it's not recommended that you screen with the free testosterone. It's recommended that the total morning testosterone be the preferred screening tool. And they have to have symptoms. It's not just a lab test. If you don't have symptoms, you don't treat. This rash, what is this rash? This is hidradenitis suppurativa. And it's a dreadful disorder. There's only been one book ever published on hidradenitis. And the authors begin with the declaration as dermatologists who are steeped in knowledge on this disorder. It's what they call a heart sink diagnosis, because there's been no good treatment. It is disfiguring, it's chronic, and it's a cosmetic embarrassment, and you get all these recurrent abscesses, and the places that you get them are axilli, perimammary, perineal, and intragluteal. And people can have multiple of these all the time. It is more common in African Americans. Yes, sir. I'm going to show it to you the name, I call it. This is the name, hidradenitis suppurativa. More common in African Americans. Also been found to be more common in smokers, as if we needed to have another reason to talk to people to stop smoking. I am really rabid about the smoking. Everybody in my family has vascular disease. My dad died at 62, MI. My mom, lung cancer. No, Dad was 57. Mom, 62, lung cancer. My older brother had his first MI at age 45 because everybody in our family has low HDL. My low HDL was in 20s most of my life. Perhaps I should hurry through this lecture from the sound of it. So I'm willing to use any excuse, and I don't think we're going to talk about it in this lecture today, but I encourage you to look up the data on children in homes of smokers. Measuring the amount of nicotine in plasma is difficult, but there's a metabolite of nicotine called cotinine. It is the A1C of smoking. It definitely correlates with how many cigarettes you smoke and how you smoke them. Because you know how some people, the smoking, it's a toy. They don't really smoke. It's just something you have in their hand or they hold in their lips, and other people suck in every possible molecule of smoke. Well, the cotinine tells you how people smoke. If you look at our cotinines, since 20% of Americans still smoke, your state has the best score, I believe, actually. Since 20% of people still smoke, We all have cotinine in our plasma. Our level is less than 1. Smokers' levels are 40 to 50. Children who live in homes of smokers, their levels are 10 to 15. And even when mom says or dad says, I only smoke outside, those kids' levels are still 10 times what yours and mine are. So when parents come in, the kid's got the earache or the respiratory infection, I say, does anybody in the kid's environment or caretakers, any of them smoke? And when they give me the business, oh, we only smoke outside, I pull out the graph. I say, look, your child is going to have more secondary smoke stuff in their plasma. It's associated with more asthma, more ear infections, more respiratory stuff. Even if you're not willing to do it for your own health, are you willing to do it for the well-being of your child? So sometimes that approaches it from a different angle. Now, the hidradenitis, nobody knows what the cause is. There's lots of speculation because it's these abscesses recurrently that are almost acneiform, which resulted in some of the therapies like Retin-A has been used, and even the Accutane has been used for this androgen, for this entity. Androgen suppression has been found to have some benefit because androgen suppression is not without risk, it's not routinely done. Well, here's a study trying to capitalize on the idea that maybe you could manipulate androgen in the skin. Remember that spironolactone is also used for acne because it works as an androgen receptor blocker in the skin. Well, finasteride prevents the conversion of testosterone to dihydrotestosterone, the active component, both in the prostate and in the skin. So this study looked at finasteride at the regular 5 milligrams per day dose in 7 patients who have refractory hidradenitis suppurativa. Here's what happened. 6 out of 7 of them, complete dramatic healing. 3 out of 7 completely healed. And the short-term treatment led to remissions lasting as long as 18 months. So these people are dramatically problemed with this burden, and we need something to try. So I have tried this now on several patients with pretty good results. It's hard to know the results quickly because when people get hidradenitis, what will happen is they'll only get 1 or 2 of these abscesses a year, and sometimes they won't get any for 2 or 3 more years. So I don't have a long enough window to tell you whether in the patients I've used in an uncontrolled setting, whether it really benefits them. Has anybody tried this for hidradenitis? How many of you have seen hidradenitis? Bless you, good, okay. So it's something else to consider offering. Now, the limitation factor is the insurance isn't going to pay for it because it's not an indication for finasteride. So they're going to have to be willing to pay for it out of their pocket. So, middle-aged man with a PSA. This is our last one. When we talk about prostate disease, there's 2 categories of medicine. There's symptom modification and disease-modifying therapy. If I come to you because I'm getting up to urinate 4 times at night, and I have a slow stream, and I void, and then I have to wait a minute and I void some more, you can get rid of essentially all of my symptoms with an alpha blocker. And you have fulfilled your medical ethical contract. I came to talk to you about getting up at night. You made it better. But you know what? You're not changing anything about my prostate. When I lecture to the residents about BPH, I remind them, BPH is asthma of the prostate. What do I mean by that? Well, when Grandpa goes to his granddaughter's wedding and goes into acute urinary retention because he took a hit of neosynephrine, it's not because he changed the size of the boulder. BPH is not a big boulder. It's like the atherosclerosis is not, we used to think it was clogged up pipes, but you know that most MI happens at less than 50% stenosis of the artery. So it's not clogged up pipes. In BPH, what you have is a proliferation of hyperreactive smooth muscle. So the smooth muscle in the bladder, neck, and prostate is highly sensitive to alpha-1 tone. So if you give an alpha blocker, the prostate relaxes. You didn't change the size of the boulder. Yes, the prostate did grow. It got more of this twitchy muscle, which is why the guys with prostate trouble, sometimes they have to go, but it's only a little bit of urine in there because their bladder neck is real sensitive because it has this hyperreactive smooth muscle, and you can block that alpha tone with an alpha blocker. Well, it has been learned in the last 5 years that if you give an alpha reductase inhibitor, finasteride, Proscar, or dutasteride, Avodart, not only do you get similar symptom reduction 6 months down the road, but in 2 trials where people have tried both medicines at the same time, you can get the immediate relief of the BPH from the alpha blocker, and then 3 to 6 months down the road, you can stop the alpha blocker and just go on with the Proscar or Avodart. Because with the shrunken prostate, regressed twitchy muscle, the symptoms go away equally well in 3/4 of the folks. But that oration is actually not about the problem we're going to look at today. It's just sort of related. This is a 45-year-old man, and he had a brother with prostate cancer. His PSA this year is 2.5, and he says, what can I do to prevent prostate cancer? And most of the time, we'd probably tell people nothing. But the AUA was on a campaign 2 years ago, based upon a trial I'm going to show you, to talk about what they call chemo prevention of prostate cancer using alpha reductase inhibitors based upon this trial, called the REDUCE trial, for reduction by dutasteride of prostate cancer. This is a double-blind trial of men who are considered increased risk for prostate cancer because their baseline PSAs are pretty high, 2.5 in young men and 3 or greater in men over 60. They have to biopsy at the beginning to make sure they don't have prostate cancer at the outset, and they biopsy them periodically during this trial. Look at the biopsies at ages 2 years and 4 years into the trial, comparing men on dutasteride versus men on placebo, looking at the incidence of prostate cancer positive biopsies. At 4 years down the road, there was a 21% risk reduction for prostate cancer if you took dutasteride rather than taking placebo. The reason I'm showing you this graph is because this is not the first trial to address this question. I'll show you the data on the prostate cancer prevention trial, a much larger trial. This is still big. This is still 7,000 men. The prostate cancer prevention trial, I think, was like 18,000 men who got finasteride. And unfortunately, in the finasteride trial, the map looked exactly the same as the one you're seeing here, with one exception. Men with high Gleason scores in the prostate cancer prevention trial were more common in men who took Proscar than in men who took placebo. And so even though in the prostate cancer prevention trial, there was also a 25% reduction in overall prostate cancers, because there was still an increase in the highest risk cancers, physicians didn't buy into it at all. Well, in this trial, there was no statistically significant increase in the high Gleason score tumors on dutasteride, prompting the AUA to say, you know what, when we see men who have BPH, we should be offering them more than one alternative. We should be willing to offer them, not only can you control your symptoms, we can control your symptoms long-term with alpha reductase inhibitors, and that men should be offered the possibility of having cancer prevention of the prostate with the use of alpha reductase inhibitors. The FDA was unwilling to give dutasteride clearance on this indication based upon the single trial, because the larger trial did not show the same result. And here's the tolerability. And the last slide is the comparison of the two trials. Here's the Finasteride data in the prostate cancer prevention trial, 18,000 folks, 7 years trial, and there was a 24% decrease in prostate cancer, but there was a statistically significant, though modest, increase in high-grade tumors, which is why it was not widely promoted that we should consider alpha reductase inhibitors for prostate cancer prevention. We're at the end of our hour, and I have time for a question, or is it end of the day? If there's a question or comment or thought on this last point, yes, miss. Our colleague says, when you're doing testosterone therapy, if you're going to treat a man with hypogonadism, what are you doing? You give a man whichever formulation you're going to give. If you're going to give topicals, which is what is recommended for us who are generally novices in this field, because you could give pellets, there's a buccal tablet that you can use, there's implants. It's recommended that you adjust the dose to get men to the mid-normal range of total testosterone. And in most laboratories, the range goes from 350 to 900. And that, because we don't know what his testosterone level was before, then that should be satisfactory for most men. If that does not satisfy his target symptoms, then it's probably not the cause of his mood or libido change. Maybe there's something else going on. So you aim for mid-normal adult range that's established in 25-year-old men, so about 700. No, only the total. It's monitored by total, not free. Right. Totals for monitoring, right? Yes. Our colleague asked, if you're giving a patient finasteride, what do you do if it's not going to rise? Because you might miss prostate cancer. If you're suppressing growth of the gland, isn't that going to distort your PSA measurements? It is. It's recommended whenever you use 5-alpha reductase inhibitors that you get a PSA level at 6 months of therapy and double that and use that number as your threshold from then on. And if necessary, you could use a PSA velocity, meaning if you increase your PSA more than 0.75 per nanograms per milliliter per year, that's too much growth of the prostate. They need to be referred. Thanks for sharing part of your day with me and allowing to speak with you.